patient skin of the neck, and then these are the deeper structures we're seeing here on ultrasound. And this is, again, the relationship between the thyroid gland and the carotid artery on the Doppler. So this is, again, a schematic representation of the thyroid gland. This in the axial or transverse view. So we have right lobe, left lobe, connected by the isthmus, and then the anterior muscles of the neck, sternohyoid, sternothyroid, and the sternocleidomastoid muscle on the lateral aspect. So immediately behind the isthmus is the trachea with bright rings, and then posterior to that, a little bit to the left, is the esophagus seen usually, and then posterior and lateral are the jugular and the common carotid vessels. Okay, much deeper than that, we have the vertebral column and the longus colli muscles, but we don't usually visualize or see these structures because, as you can see, the thyroid ultrasound images don't go deep enough because we want high resolution evaluation. So the higher the resolution, the less shallow or the smaller anterior posterior dimension that the ultrasound beam can go. Okay, so it's a trade-off. It's an inverse relationship. As the frequency and resolution goes up for ultrasound, the depth of penetration goes down. Okay, so again, we have normal range as far as the thyroid gland measurement. So it ranges between 4 to 7 centimeter for length, 10 to 3 centimeter for width, and 1 to 2 centimeter for depth. And the isthmus is always less than 5 millimeter in thickness. And as far as the total volume, it should be less than 25 ml in men and less than 20 ml in women. Okay, and this is how we calculate the volume. Okay. Here, normal thyroid gland, we have it at different levels. This is at the upper aspect or the top level of the thyroid gland. We see the right lobe, left lobe, and the isthmus. Again, hold on a second. Let me try to do something here. So again, yeah, the anterior here at the mid level, we still see the two lobes, the trachea, excuse me, the infrahyoid strap muscles, and more inferiorly with color Doppler, we see normal flow to the gland and the carotid artery on each side. Yes.
المؤشر مو واضح.
اوكي. طيب دقيقة. الآن
لسه مو شايفين.
طيب خلينا نشوف شيء دقيقة. طيب الآن
أيوة.
طيب كويس. طيب سجلوها. هي بتتسجل already صح؟ طيب. Okay, so so these are two different levels. So here we have the thyroid gland with trachea. The isthmus connects the right and left lobes, and we have the infrahyoid strap muscle. Again, a little bit more inferiorly, we start seeing the carotid, the common carotid arteries, tracheal rings, and the esophagus sits here. Okay, and this is with color Doppler. We see the left and right carotid artery flow, and normally there is some flow seen within the thyroid gland itself. Okay, so as I mentioned, thyroid imaging of the thyroid gland is by using ultrasound as the first line. whether it's for abnormal thyroid function test, whether it's for a lump or a mass, whether it's for suspicion of like malignancy or enlarged lymph nodes. So we always start with ultrasound. And the patient is hyperthyroid. A thyroid scan, which is an example of nuclear medicine study, can also be used. Okay, so as far as the if you have a lesion, as far as the benign versus malignant features on ultrasound for these nodules, how do we differentiate? I want to begin that we can't really say 100% that this lesion is 100% benign or this lesion is 100% malignant. There is some features that we look for, and if it looks suspicious enough for us, we would recommend doing fine needle aspiration or a biopsy. Okay, there are some lesions that are very, very benign looking, and we'll probably see examples of those, but some of them we can't really tell if there is a possible malignancy hidden behind it. Okay, so focal lesions with all criteria of simple cyst. Okay, if the lesion looks as a simple cyst, meaning it has a thin wall with smooth margin and looks completely anechoic, there is no internal echogenicity, completely black. Anechoic means completely black, not dark, but completely black. Okay, and there is enhanced through transmission or posterior acoustic enhancement. This usually means it's a benign cyst or a simple cyst. Okay. Once the cyst becomes more complicated, meaning it has large septation, it has nodular component, it has internal flow, these are features of suspicious or suspicion for malignancy. Okay, calcifications could be seen in either conditions. Could be seen in benign conditions. It also can be seen with malignant lesions. Specifically, if we see microcalcifications. Okay, once you hear a thyroid gland lesion contains microcalcifications, this is very suspicious for malignancy. Okay, microcalcifications means the calcifications are very small, like dots of calcification. It's not like bulky areas of calcification, just like small dots of calcification. This is very suspicious or has high chance of malignancy. Okay, and then as I mentioned, if it's suspicious enough and we cannot 100% say it's benign, we usually go for FNA to send for cytology. Okay, so this is an example of an FNA. This is a hypoechoic, a dark thyroid nodule that has areas of calcifications here, and this is the needle going in to take few cells and to send it to the lab for cytology. Okay, so FNA is very reliable, and it can differentiate suspicious from benign nodules. Okay. So advantages of ultrasound, it's accessible. It's available in most, if not all, hospitals. It's inexpensive relatively to other imaging modalities, and it's non-invasive. Okay, it's quick, highly sensitive for cysts versus solid lesions. It can identify cysts as small as 2 millimeter, and also it can identify solid lesions as small as 4 millimeter, right? And also can identify structures, lesions other than the thyroid gland itself. Okay, we can look at lymph nodes, presence of metastatic disease in the region or not, and so on. But of course, ultrasound has a lot of limitations, and it's the main limitation. It's operator dependent. Okay, so the quality of the images depends on the person who is doing the scan. It's not like CT or X-ray. You just put the patient inside the machine and do the images. No, the ultrasound, because it's hands-on application or examination. It has operator dependency. And also it is inferior to cross-sectional imaging such as CT and MR for identifying lymph nodes and metastatic disease. All right, so let's take an example of a very known condition. Involves the thyroid gland, which is Graves' disease, also known as toxic diffuse goiter. Typically, patients presents with goiter and classic signs of hyperthyroidism. As far as the gland itself and what we see on imaging, the gland would be very swollen, especially the isthmus, more than 5 millimeter, and on imaging diffusely hypoechoic, meaning it looks decreased in echogenicity compared to normal structures and compared to normal thyroid gland, okay? Because of all the hyperemia and inflammation that is happening in the thyroid gland, it looks decreased in echogenicity. Okay, so this is the normal thyroid gland. So we have the left lobe here, we have the right lobe here, we have the isthmus connecting the two. But compared to a Graves' disease thyroid gland, looks like very decreased, much darker than the normal thyroid gland. So this is an example of a Graves' disease. And when it comes to the color Doppler, when we assess the blood flow to the thyroid gland in cases of Graves' disease, if you remember that that first image with color Doppler had few lines of flow, which was normal, but this one has marked hyperemia or increased vascularity to the flow, which is another sign of Graves' disease that can be visualized. Okay, so this is ultrasound imaging of the thyroid gland. Any questions so far? It will move on to thyroid scintigraphy, which is an example of nuclear medicine scan. So it's different. It's different from ultrasound. It's different from X-ray. Different from CT. I don't know. Did anyone talk to you about nuclear medicine in general? Did you take any lecture about nuclear medicine?
Yes.
Okay. Yes. Okay. Excellent. So you have some information about it. Okay. So it is. So as you know, it's a functional imaging. It gives you functional information, which is different from ultrasound. Ultrasounds give you anatomic information, does not give you the function of the gland. Okay, so it can evaluate the nodules in the thyroid glands, the nodules or the masses, and we can determine if it's hot nodule versus cold nodule. If it's hot, we call it hot nodule if it takes more radiotracer compared to the rest of the gland, and we call it cold nodule if it takes less radiotracer compared to the thyroid gland, and we'll see examples of each one. Okay, so we have different isotopes to image the thyroid gland. The preferred one is iodine 123, and sometimes we use technetium 99M pertechnetate, but this is not as commonly used as the iodine 123. And for treatment and for evaluation of metastatic disease, we use iodine 131 radioisotope. Okay. So the patient takes the radioactive material, the radioisotope, whether it's a capsule or a liquid, and then, or could be injected intravenously, but nowadays most commonly it is taken orally. And then we have to wait for a specific amount of time for the radiotracer to be distributed in the body and to accumulate in the thyroid gland. And usually we wait for 24 hours after the patient has taken the pill or the liquid that contains the isotope, and then we image the patient. So how it's done? The patient presents to the nuclear medicine department after like 24 hours after taking the radioisotope. This is the gamma camera that is used to image the thyroid gland, and we put it very close to the patient's neck, and this is the image that we expect to see. Okay, so this is a frontal view of the thyroid gland. This is the right, and this is the left lobe, and this is the isthmus. All right, so this is an example of a normal thyroid gland in thyroid scintigraphy scan. So you see, it doesn't give you anatomic details. The gland itself looks very fuzzy and hazy. The edges are not sharp, but gives you the function. Okay, so this is the advantage or the utility of nuclear medicine. It's a functional scan rather than anatomic scan. So we usually combine the two. We do ultrasound to provide anatomic details, and then we do thyroid scintigraphy to provide functional details. All right, so normal size, normal uptake, symmetrical uptake in both lobes, and homogeneous uptake in the isthmus as well. All right, so there is no cold or hot nodules that we see. Comparing it to this one, this is a thyroid gland in a different patient showing a focal hot nodule. This is an example of a hot nodule, meaning it takes more radioisotope compared to the rest of the gland. And so an area of increased uptake means, so whenever we see a hot nodule on a thyroid gland, this is almost always a benign nodule, okay? So remember that hot nodule means benign nodule. Okay. So I know the name can be misleading, but try to remember hot nodules are unlikely to be caused by cancer. So most likely they are benign. On the other hand, if we see a nodule with decreased uptake, this is an example of a cold nodule. It retains much less radio tracer compared to the rest of the thyroid gland. This is a cold nodule. It doesn't necessarily mean it's 100% cancerous, but there is higher chance of being cancer than the hot nodule, okay? So cold nodule could be cancerous, so it is suspicious. So we might also go further and take a biopsy or do fine needle aspiration for cold nodules only, okay? Hot nodules, they're almost always benign. Okay, so different condition. Here we see the entire gland is markedly enlarged. Okay, it looks much larger than the normal image that we look at it here. All right, and not only enlarged, but there are multiple different nodules. Some of them are hot, like these, and some of them are cold, like these. So this is an example of multinodular goiter. Okay, so a different condition that can affect the thyroid gland, which is known as multinodular goiter. Okay, so multinodular enlargement of the thyroid gland can be associated with hyperthyroidism in some cases. All right, so this is on this image. I know it's somewhat tricky to know which one is normal versus enlarged only by nuclear medicine, but we have to do the ultrasound and take the measurement. That's why that's how we know. So in this patient has simple goiter, okay, it has enlarged thyroid gland, but normal activity, normal uptake. This is a different patient who has enlarged gland, but also increased activity, okay? So this is to differentiate. The gland here looks large, but normal uptake, but this one has Graves' disease with increased size and activity of the gland, okay? In some patients who has enlarged thyroid gland, the gland itself might descend deep and behind the sternum, which is called a substernal or retrosternal goiter, okay? Normally the thyroid gland lives here, but sometimes if we see activity extending underneath the thyroid gland and behind the sternum, the expected location of the sternum, This is called retrosternal goiter. Okay, sometimes because why this is important, because on other imaging such as chest X-ray, for example, we will see the effect of this enlargement. How? We will see deviation of the mediastinal structures. We will see deviation of the trachea to the other side. We'll see, deviation or maybe like a mass, something that looks like a mass on X-ray. So it is important to know if the patient has retrosternal goiter or not. Okay, this is what I'm trying to say. See, there is deviation of the trachea, which is supposed to be midline here in this patient who has substernal or retrosternal goiter, and this is on CT how it looks like. It's very heterogeneous and pushing the trachea towards the right. Okay, so again, just to summarize, we have different examples of thyroid scintigraphy. We have normal thyroid, we have Graves' disease, we have multinodular goiter, we have solitary toxic adenoma, and we have very poor uptake diffusely in the gland, which in this case can be seen with active thyroiditis. All right, so now we are done with the two most commonly used techniques when it comes to imaging the thyroid gland itself, which is the ultrasound and thyroid scintigraphy, nuclear medicine scan. Okay, we're going to move on to cross-sectional imaging of the neck and thyroid. So when we do CT and MR, we don't usually do them to image the thyroid gland itself. We use these modalities to image the other structures surrounding the thyroid gland, such as the vessels, lymph nodes, salivary glands, muscles, and so on. Okay, so this is a very important distinction. So we don't typically use CT and MR to image the thyroid gland, although we can see the gland very clearly, but we always start with ultrasound. Okay, so it gives us CT and MR give us more anatomic details, and we will see the entire thyroid gland at once. We'll see a lot of all the lymph node involvement in cases of metastatic disease. Also, we'll see extension of the thyroid to the adjacent tissues in the neck and the mediastinum, and also see the other structures. Okay, so when we image the neck with CT, we always do it with intravenous contrast, right? So normally the thyroid gland itself, because it contains iodine, in CT it will show enhancement. It will look enhancing because the intravenous contrast has iodine, and the thyroid gland itself has iodine. So we see the thyroid gland is more bright compared to the other organs, even without giving contrast. All right. So because we the neck, the CT of the neck without contrast can be very difficult to read without intravenous contrast, because sometimes you cannot really evaluate lymph nodes from vessels and things like that. Okay. This last bullet point here is very, very important. Okay. If the patient received a CT scan with intravenous contrast, okay, and they have a nuclear medicine scan scheduled afterwards, they have to wait for at least 4 to 6 weeks before doing the nuclear medicine scan. Why is that? Because the intravenous contrast for CT, the iodinated contrast, will interfere with the iodine uptake of the radioisotope by the thyroid gland. Is that clear? This is a very, very important point, very important clinical point. So if the patient is coming in with 2 appointments, one for thyroid scintigraphy, thyroid nuclear medicine scan, and one for CT of the neck with intravenous contrast, we have 2 options, okay? We either do the isotope, the nuclear medicine scan first, and then do the CT scan, or if the patient has a CT done with IV contrast, because the thyroid gland will take some of the IV contrast and this will interfere with the uptake of the radioisotope when it comes the time for the nuclear medicine scan. So the patient has to wait up to 6 weeks after the CT contrast with the CT with intravenous contrast before doing a thyroid scan. Otherwise, the scan will be suboptimal. All right. So just few images of the neck. So we see the carotid vessels. We see the carotid artery and jugular vein filling with contrast. We see the sternocleidomastoid muscle. We see the infrahyoid and strap muscles. We see the platysma. So this is the above the level of the thyroid gland. Now we're moving downward a little bit. We're seeing the right lobe of the thyroid gland. We are seeing the left lobe here. Again, we see the carotid artery, the jugular vein. See how nice and well enhancing these structures are. And yeah, so the muscles and soft tissues, everything. So we see some lymph nodes in the neck also. So it really helps with giving intravenous contrast. Right. This is even more inferiorly. We see the left lobe of the thyroid, right lobe, trachea, and the vessels and the anterior muscles of the neck. Okay, so MR of the neck with and without contrast is also appropriate when there is concern about contrast issues in renal patients or contrast allergy, but it's not commonly done. All right, this is an example of an MR image. This is the thyroid gland. On MR, we see the close proximity again of the carotid vessels. This is the trachea, and this is the esophagus here. Okay, this is the cervical vertebral body. This is spinal cord, and these are the anterior neck muscles. But again, the MR is not typically ordered to image the thyroid gland. CT sometimes. CT is sometimes ordered to image the gland itself, especially if it's to see if it extends inferiorly into the mediastinum. But as we mentioned at the beginning, typically we always start with ultrasound, and then if needed to evaluate the function, we do nuclear medicine scans, also an add thyroid scintigraphy. Okay. I'm done with the first talk. I'm done with the neck lecture. Here are the references and resources for you to read. And if anyone has any questions, I am more than happy to answer.
دكتور عندي سؤال.
تفضل.
بخصوص في تيست اسمه Radioactive Iodine Uptake Test، هو نفسه الثايرويد سكان اللي أخذناه؟
ايوه نعم، شبيه فيه. هو nuclear medicine. نعم. Radioactive Iodine Uptake. So يعني it's a longer name. يعني thyroid scintigraphy, radioactive iodine uptake. هو it depends on the radioisotope that is used. يعني ايش النظائر، اسمه النظائر المشعة، أي واحد من الخيارات اللي موجودة اللي استخدموه. بس هو it depends on the history of the patient, if this is a new diagnosis or not, if this is a follow-up or not, if this is a treatment of metastatic disease. So it depends on that, on the history. They will choose different anatomic or different radioisotope agent. Does it answer your question?
تمام، شكرا دكتور.
All right. Any other questions? Okay, so for now, I am going to switch gears. So we are supposed to take supposed to do the review, right? The revision for what is it? The abdomen and neck, I believe. Is that right?
Yes.
Like, okay, so this one is going to be different. This one is going to be interactive. So I am going to ask you all to participate. So I either have some of you volunteer, and then